Hello everybody. Today we're going to be talking about and reviewing how to look at imaging. First, let's talk about ergonomics. Your background lighting should be similar to the brightness coming from your screen. Make sure you don't have any glare. You want to be as far from the screen as possible and still see the image and reach your mouse. For cross-sectional imaging where resolution is less important, we want to have more sequences and reformats on the same image or on the same screen. I like at least a 2x3 as I've kind of set up here for us. You're trying to optimize what's in the field of view of your fovea. Remember that for the sake of imaging, we don't see things in our peripheral vision. Peripheral vision evolved to see tigers lunging out at us, not at lung nodules. You want your fovea to see as much of the image as possible when you're scanning. Review any image or series of images in a stepwise fashion. It doesn't matter what pattern you use, as long as you're using the same pattern every time. And again, you don't have to use my approach, but you have to use an approach. This will increase your sensitivity to any abnormalities. For reviewing head CTs, first I start by looking at the extracaveral soft tissues. Look at the skin, subcutaneous fat, muscles of mastication, parotid glands, what we can see of them. Make sure there's normal fat within the pterygopalatine fossa, and you'll see small vessels and nerves as well. Then review the orbits. Then I move to bone windows. So we're using an outside-in approach where we look at everything on the outside, then work our way in. Some people might use an approach where they start by looking at the bones, then move on to soft tissues. The key is to use an approach where you don't forget something that's not the primary area of interest for the diagnostic test that you're doing. On a CT of the chest done for looking at the lungs, you would look at the chest wall first. You don't forget to look at it. For looking at the bones, look at the calvarium, skull, then look at the mastoid air cells, the middle ear, where we can see the ossicles. Remember, this is not a dedicated temporal bone CT, but we can still see much of the middle ear and inner ear anatomy. Petrous apex. This patient happens to have a pneumatized petrous apex on the left, which is a normal variant. Look at the clivus, the normal foramina, foraminal valley, foramen spinosum, hypoglossal canal, carotid canal, jugular foramen. Look at the sinuses. Now that we've reviewed the osseous anatomy, we want to move to inside of the head, inside of the skull. If we're looking at inside the head, I usually look at blood windows first. Now there are two different types of scanning approaches. Some readers use a drilling pattern where they're looking at the same area on the image and scrolling up and down. And then some readers will look at one slice at a time and scan the entire image. Either approach is valid. I tend to use a combination of the two. When you're looking for blood products, make sure to check the dependent areas such as the interpeduncular cistern and the sylvian fissures. And since we have reformats in every plane, we want to look at the same windows in each plane. Now let's move to looking at the ventricles, the ventricular caliber, any mass effect on the ventricles. Next, let's look at gray-white differentiation. We want to make sure we see the normal basal ganglia, including the caudate, the putamen, the globus pallidus, the insular ribbon, thalamus. Cerebellum. Cerebellum can be helpful to review gray white differentiation in the coronal projection, as small infarcts can be obscured on the axial projection. Again, we look at the gray-white differentiation on every reformat. And now when I dictate the case, I look at the same structures, but I go in reverse. I say there's no acute hemorrhage, comma mass effect. The ventricles and extraaxial spaces are normal. The calvarium and extracalvarial soft tissues are unremarkable. And then my impression would be that this is a normal exam. Now for cervical spine, and for any spine imaging, whether it be X-ray of the cervical, thoracic, or lumbar, or CT, or MRI, the approach is very similar. And what we do is we look at first alignment. Always look at alignment first and report the alignment first. So as I'm looking at this, I would say there is straightening of the normal lordosis in this case. And then I look at the bone second here. If it was an MRI, I'd be looking at the marrow. And as I'm looking up and down, what I'm going to do is I'm going to look at the facets on one side and make sure they're aligned appropriately and that there's no evidence of fracture of the joint. And then I'm going to go to the other side. I'm going to do the exact same thing. And then I'm going to look at each vertebral body as I scroll back and forth, making sure there are no fractures and no evidence of compression of the vertebral body. I'll also look at the cranial cervical alignment, make sure that the clivus and the dens have a normal relationship with each other. And then I'll look at the same anatomy, the same alignment, and then look at all the facet joints and the vertebral bodies and the cranial cervical relationship in the coronal plane. Then I'll do the exact same thing in the axial plane. And as I'm scrolling up and down on the axial plane, I often look on one side and then the other, looking for transverse process fractures on the axial, facet fractures, and vertebral body fractures. Next, I want to look at the soft tissues. Make sure there's no prevertebral soft tissue swelling. And also look at the canal. Make sure that there's no epidural hematoma or large disc extrusion. Also want to look at the soft tissues on the axial plane. Make sure we're not missing an incidental parotid mass or any mass within the aerodigestive tract. And also look at the lung windows. Look at the lung apices for incidental nodules or pneumothoraces. And make sure we review for rib fractures and clavicular fractures. Remember that you don't have to use the same approach I do, but you want to use an approach that you come up with and that works for you. As you develop your algorithm for reviewing imaging and you find that you miss certain types of findings, you want to adjust your algorithm to make sure that you don't miss those findings in the future. Thank you all for joining me for this. I hope you find it helpful, and thank you very much for your time.